Okay, but I think we can start. So welcome everyone. My name is Katja and I will act as your host today. I lead research at a Finnish company called DeepScan Diagnostics. We develop diagnostic tests for companion animals. Our first test is a cell-free DNA-based test. It's out on the market now in Scandinavia, and we are rolling it out to the rest of Europe later this year. I would like to mention two things before we start. First, this webinar will be recorded. We will share the recording to all participants after the webinar. And second, we will have time for questions throughout the presentation and also after the talk. So please use the Q&A button. It's at the bottom of your Google Meet screen under activities. So please add any questions and comments that may come to your mind during the presentation. I will read those out loud. But without further ado, this is the third talk in our webinar series. Today, I am absolutely delighted to welcome Dr. Gerry Polton, who is the hospital director at the North Down Specialist Referrals in the UK. Now, Gerry is a world expert in canine anal sac tumors, and today he has graciously agreed to give us a talk about them. Gerry, please, the floor is yours.
Thank you, Katja. Hi, everybody. Just to restate what Katja said, if you've got questions or comments, please ask them during the webinar. I know that's not normal, but I find it easier to respond to questions at the time that they come to mind. And I also find that it's better for the audience too if we can talk about things that I didn't explain very well or that are relevant to something that you've done today or recently, because I'm sure other people in the group will feel the same way. So speak up in the only way you can in the webinar, which is using the chat function. So canine anal sac gland carcinoma, yesterday, today, and tomorrow, ? So what I'm going to do is I'm going to start by talking about anal sac gland carcinoma as it was, and we'll move on to where we are now. And we may focus a lot more on where we are now, because that's relevant to what you do every day. But we'll also enjoy ourselves just thinking about what's going to happen in the future. And we're kind of using anal sac tumors as a tumor model, as a model for all cancers, because that's why I like this story so much. I think that we can look back and see the discoveries that have been made, and we can predict similar discoveries with other tumors using this excellent substrate. So anal sac gland carcinoma, that's what we call it now. It's had many names. People like making abbreviations of the names, Agasaka being the one that people seem to like. But this is a tumor of the apocrine glands of the anal sac. When these tumors were initially recognized, the syndrome of disease that was recognized was a tumor of almost exclusively female dogs, which is interesting and strange. Patients who were presented with big tumors that were bleeding, causing significant defecatory problems. And almost all of these cases were associated with hypercalcemia of malignancy. And these patients were very sick. And the photo that I've got here is of a dog called William. He was a boy, not a girl. And this is quite a small tumor compared to the tumors that were diagnosed when this was first identified as an entity. The high prevalence of hypercalcemia is interesting. So in the, I don't talk about this in a later bit, so I'll mention it now. We've identified since the 1970s to the late 90s that hypercalcemia arises in about 1/4 of anal sac gland carcinoma cases. But the interesting bit that I want to say to you is that we've followed a number of these cases up, and what we find is that as their disease progresses, some of them will develop hypercalcemia. So the hypercalcemia seems to be connected with the burden of disease, not just it being a toss of the coin whether your patient has hypercalcemia or not. Another thing that's relevant around hypercalcemia is that this contributed to the overall belief that hypercalcemia was an oncological emergency. And this is something I've been pushing back against for a long time. I accept that these patients discovered in the 1970s and 1980s perhaps were considered to be emergency cases, and I accept that if an appropriate intervention was not performed, that these patients would deteriorate very fast. But I don't accept that the hypercalcemia arose suddenly and needed sudden intervention. In fact, as I've just said to you, we've tracked cases of advanced anal sac gland carcinoma as their burden of disease has got greater, and we've demonstrated the development of hypercalcemia over a long, slow time period. And these patients are often exceptionally well despite their hypercalcemia.
Gerry?
Yes.
I have a question about hypercalcemia. So you also see this in some other types of cancers.
Absolutely.
So you mentioned that it is linked to the burden.
In anal sac tumours, that's a really good point. So in anal sac gland carcinoma, it is definitely linked to the burden of disease.
Yes.
So in lymphoma, as the principal other canine cancer that presents with hypercalcemia, it's linked with the type of lymphoma. So there are specific lymphoma entities which are associated with hypercalcemia. In very simple terms, we see a lot more of it in T-cell lymphoma than we do in B-cell lymphoma, but it goes much deeper than that. So the specific entity in dogs, which is a cranial mediastinal lymphoma, is associated with hypercalcemia, I would say, in 80% of cases. So if we see a hypercalcemic dog whose anal sacs are normal, the first thing I'll do is stick an ultrasound probe on their chest just in front of the heart. And that's a very quick way of diagnosing the underlying cause of disease in a lot of those cases.
Right. Okay.
Thank you for the question, and thank you for engaging. That makes me very excited. This could be a really good webinar.
Thanks.
So back to the oncological emergency idea. I think what happens in a lot of these cases, and I think where this notion of it being an emergency comes from, is that these patients are presented to veterinary surgeons in a state of significant physiological chaos, physiological disturbance. And a tumor was diagnosed, or maybe the patient was anesthetized in order to diagnose a tumor. And anesthesia is the disaster here. So anesthesia takes a patient with elevated calcium and it drops their blood pressure through the floor. Calcium needs to be tightly controlled in order for the natural tone of our venous circulation to be maintained. So hypercalcemia reduces the responsiveness of our venous circulation to blood pressure increasing messages. If we add to that general anesthetic, which would normally trigger those kinds of regulatory responses because it lowers blood pressure naturally, the patient has no response to that. We've probably already got renal damage because of the hypercalcemia and the natural dehydration that induces, as well as the calcium crystals forming in the kidneys, among other places. So hypotension, hypercalcemia, calcium crystallization in tissues, put all these things together, and you get a patient who could die soon after that anesthetic. And so the vets at that time did the best they could and said, oh my goodness, if only we got to this patient sooner, everything would have been fine, not realizing that it may have been their intervention which made it not fine. This patient was probably hypercalcemic for 6 months, 9 months even, before it was initially presented. I've written here end of epoch. I'm just being fancy with my language, but I suppose I'm just saying that at the end of this sort of first stage of anal sac gland carcinoma history, we had individual cases reported in isolated meeting abstracts of dogs who'd been noted to have the diagnosis, but not to present with this kind of end stage impossible tumor that was too big to enable defecation. We're starting to notice that some of these patients could have an average size tumor, let's say the size of a potato, and also develop sublumbar lymphadenopathy. And 1 or 2 centers were starting to undertake surgery on these cases and demonstrated that with lymph node removal, these patients can enjoy a prolonged survival. And so we started recognizing this tumor and thinking this is a tumor with no real therapeutic options and a very short time frame to death, probably, I think, accelerated by our best intentions and best endeavors when there was hypercalcemia, which was most of the time. And then towards the end of this period, people are starting to recognize that there are some cases where the disease progression is slow, and actually there are things that can be done which appear to extend survival. The cheeky part of me does wonder what would have happened to these patients that had lymph node removal if they hadn't had the lymph node removal. There was always an assumption that that made a big difference. It probably did. So then we move to what I'm calling today. So that's from the early noughties to where we are right now. And this is where we started to notice many more differences. So we've gone from defining this as a single entity. So in the 1970s and 80s, any tumor called an anal sac tumor was thought to be a big tumor, making it impossible to defecate, not compatible with life, associated with hypercalcemia. All of these patients were put into the same basket. Then we started to notice that there were differences, probably because we're starting to diagnose them at an earlier stage. But once people start to diagnose things at an earlier stage and recognize that there are differences, so people start asking the right questions and saying, well, what can we do that makes a difference to different patients? So there were lots of things that we noticed that were different. We noticed some significant epidemiological findings. So for example, there seemed to be a remarkable predisposition for this tumor in the English Cocker Spaniel. They had about an 8-fold increase in risk compared to crossbreed dogs, which, as I investigated at the time, is comparable to the risk of you smoking 20 cigarettes a day for 25 years and developing lung cancer versus someone who's a never smoker. So being an English Cocker Spaniel massively increases your risk of getting this tumor. Other spaniels are at increased risk, but not to the same extent. We looked at the gender bias, and extraordinarily, well, perhaps it's not so extraordinary, but there were 49% of cases in this big study that we did. 49% were male, 51% female. Clearly, that's the same. There's no significant difference between those two observations. But it's interesting and bizarre that for the best part of 20 years, there was this belief that this was a tumor that almost exclusively affected female dogs. I even remember reading a case report where a male dog was affected, and this was fanfared as something of an extraordinary thing. I've mentioned to you that approximately 1 in 4 cases will develop or has hypercalcemia at the time of diagnosis. That's been repeated over a number of different studies, and we've gone into that in a bit more detail since. The final point to make here is that over the course of this period, what we've demonstrated is that, well, we demonstrated at the start of the period, we demonstrated that clinical stage is really, really important. Clinical stage defines outcome. But with this tumor, and this is where I think today this tumor is an exceptional model for other cancers, other cancer types, the clinical stage enables us to treat patients differently according to the burden of disease.
Can I ask
Yes.
the previous slide? So what's happened to the gender difference? So where the male cancer was just not seen, it was people were not looking for it, or
I wonder if I think there's in this time there's a significant change in pet ownership habits. And I think in the 1970s, in the UK, breeding bitches were afforded more care than working male dogs. So vets were expensive. You would think twice before seeking veterinary advice. And if a male dog aged 10 had a big bleeding thing by his anus, he'd be euthanized. Nobody would have diagnosed it. I think it reflects a genuine difference in the motivation of the owner to seek an answer rather than a difference in the disease. Which stands up to, that argument makes sense when you then look at the data we got in the noughties, which says, look, it's exactly 50-50 effectively. There isn't a difference. So we have to look at for a non-biological difference. But I find that fascinating too, because that could still happen today. Not that exact scenario, but we look for biological differences, we look for tumor differences, or we look for cancer patient differences, but we don't allow ourselves the luxury sometimes of looking for owner differences. But I think that's what it was. It's a great question, and I don't know for sure, but I think that's what it was.
Yeah, no, it makes sense. Thank you.
Thank you. So this is a graph which demonstrates survival outcome for anal sac gland carcinoma patients according to their clinical stage. I'm going to make my mouse move so I can see that. I hope you can too. And we'll start over at this side, over on the left. And this line represents the time to death for all patients who had distant metastasis. We call that stage 4. So that could be metastasis to lungs, liver, spleen, bone, brain. Mostly it was lungs, secondly liver, and combinations of these. The next one along, this is patients. Well, actually, let's consider the next 2 lines together. These 2 lines represent patients who had lymph node metastasis. The line on the left is for patients whose lymph nodes were 4.5 centimeters in diameter or more, and the line on the right is for patients whose lymph nodes were less than 4.5 centimeters diameter. The next line is patients without any metastasis, but with a primary tumor that's 2.5 centimeters or more. And the last line is patients without metastasis whose primary tumor is less than 2.5 centimeters. These numbers, 2.5 or 4.5 centimeters, were defined by undertaking a number of different mathematical manipulations of the data to find the sizing that most demonstrated a difference. And it's interesting, but this work was published in 2007. We've done more work which was published, I think, in 2023, which tried to improve on this, and we couldn't. So this model still stands today, that the 4.5 centimeter and the 2.5 centimeter thresholds seem to put patients into different prognostic groups. Once we'd started to recognize differences, we then started to ask ourselves, oh, well, which of these differences in patient characteristic will actually have an impact on survival? So we recognize that clinical stage does, but we then try and layer on top of that other differences, thinking, wouldn't it be fascinating if English Cocker Spaniels actually all lived longer than Dobermans with the same diagnosis and the same burden of disease, the same clinical stage? And I thought they did. So there's a reason I said that, is that we thought English Cocker Spaniels did live longer. And the reason we thought that is because we kept on seeing those patients. They kept coming back again for more care. But it turns out they didn't live longer, because they were Cocker Spaniels. It's just that their owners, back to that point, were more likely to come and see us. So perhaps their owners are more needy. I apologize to all the English Cocker Spaniel owners on the call. Other things didn't make a difference, were whether the patient was neutered or intact, male or female. That didn't surprise me. You get different kinds of anal sac tumor histologically. which represent different degrees of differentiation. So the tumours which really resemble anal sac tissue, it would be reasonable to think that they might have a better prognosis than ones which really don't resemble anal sac tissue very much. But we didn't ever demonstrate that that was true. And I wonder if that might be because we just didn't have enough of some of the less frequent subtypes, but we failed to find a relevance to it, which means people shouldn't be wasting their time looking for that when they're treating the patient in front of them. I put age in brackets because age did have an impact on survival, but you'd sort of expect that. A patient who's 5 who develops a tumour could live another 10 years even. A patient who's 14 when they develop a tumour cannot live another 10 years. And although the mathematics said that age was relevant, I felt that it probably wasn't in the manner I wanted it to be. And what we did demonstrate was that hypercalcemia did appear to have prognostic significance, but we will come back to that idea, and that E-cadherin had prognostic significance, which is a really interesting one. So let's talk again about hypercalcemia. And I've made a reference to this already, but to discuss it properly, it was shown repeatedly in studies from 2000 to 2012 that patients with hypercalcemia lived less time than patients without. But as I've already told you, I felt that we had evidence that hypercalcemia was something that was associated with a bigger burden of disease. And we already know that with a bigger burden of disease, they had a poorer prognosis. And we couldn't prove it from the big data set we had. So we ended up doing a different study where we took 25 cases with hypercalcemia, and then we found 25 patients without hypercalcemia who had exactly the same burden of cancer. So we matched them for primary tumor size, lymph node metastasis, presence or absence, and lymph node size. And we matched patients who had lung metastasis with non-hypercalcemic patients with lung metastasis, for example. It was really difficult to do this because as patients got more advanced disease, so they seemed to keep on getting more hypercalcemia. But we managed to find these 25 paired cases. And when we compared their survival, yes, it's true, there was no statistically significant difference, but actually when you compared their survival, there was no difference at all, never mind the statistics. You could see the two lines were exactly on top of each other. So I do, it's true, hypercalcemia is of significance. When you get a patient in your clinic, you prove that it's got high calcium, that's going to have a worse prognosis than a patient who doesn't have high calcium. But the reason for that is because patients with high calcium more often have a more significant burden of disease. So it's a clue you need to go looking for more advanced disease. Don't fall into the trap of thinking this is just a dog with a small anal sac tumor, and if I take that anal sac tumor out, the calcium will go back to normal. It could, but I reckon you've got about a 2% chance of that. Much, much, much more likely that they've got metastasis to lymph nodes, spleen, liver, lungs, something. I think I've answered the how can hypercalcemia be an oncological emergency question already. So I made a casual reference to something called E-cadherin on the slide before the last one. E-cadherin, you may be very familiar, you may not. E-cadherin is a molecule which is expressed on the outer surface of epithelial cells, and it binds those epithelial cells together, so it makes them stick to each other. One of the characteristics of metastasis is, of course, that tissue must have the ability, the cells in that tissue must have the ability to separate from the rest of them, to survive separation, to migrate into a blood or lymph vessel, to avoid the immune system, and then to come out of the blood or lymph somewhere and set up home somewhere else. And if E-cadherin is this really great adhesion molecule, you'd need to have a strategy for disengaging that E-cadherin in order to become metastatic. So our theory was that there might be some kind of prognostic relationship between anal sac tumors that had higher levels of E-cadherin and anal sac tumors that had lower levels of E-cadherin. So a high level of E-cadherin expression would mean lots of stickiness, and low levels would be weird because it's normal for epithelial tissues to express this. Low levels would mean less stickiness, higher propensity, higher ability for metastasis. So we tested that. We got a bunch of anal sac tumor tissue specimens, stained them for E-cadherin, and put them into 3 groups: tumors with more than 3/4 of the cells staining brightly positive, tumors with 25 to 75% staining positive, and tumors with less than 25 staining positive. And what we found was there was no difference regardless of where they were from 0 to 75%, but if they were more than 75% positive, they had a better prognosis. And that's shown in the graph here. So the solid line is the patients who have more E-cadherin, more stickiness, less likely to undergo metastasis. And when we put that into our big model that we'd made to stratify the patients into different clinical stages of disease, which we've already looked at the graph for, what we found was that if you put the E-cadherin staining in, that suddenly lymph node metastasis didn't really have that much relevance anymore, but distant metastasis did. If you forced the lymph node metastasis in, then the E-cadherin didn't really have that much relevance anymore. Although they weren't completely top and tailing each other, completely replacing one with the other, it felt like this E-cadherin expression or lack of expression was linked with the ability to spread through the lymphatics into the lymph nodes and set up lymph node metastases. But it felt like it didn't have any impact on the spread, I guess, via the bloodstream to form distant metastases. So we speculate that those are 2 different metastatic pathways, and we didn't ever recommend on the basis of this work that people started staining for E-cadherin, because it's simpler to just do a decent ultrasound or a CT and see if there are lymph node metastases, rather than do a test which tells you that there might be lymph node metastases, which you then need to do an ultrasound or CT for to confirm. But it was interesting. So this is the clinical stage scheme that we now use. So this is the written form of what I was just explaining as we were looking at the graph. And we, based upon these 5 different stages, we make different decisions with our patients. And back in 2007, we actually developed a decision tree, for want of a better word, based upon what was practical at the time and the results of the study which led to those clinical stage stratifications. At this point in time, we knew that radiotherapy seemed to work some of the time, but we didn't have either the technology or the case number to really make clear recommendations for radiotherapy, which is why there are dotted lines down here. So probably a good idea, not totally sure yet. So I'm going to show you some pictures just to characterize these better. This is a little dog called Tipsy, a Cocker Spaniel, surprise, surprise. And Tipsy is remarkably well. This can happen. You can have a patient who's got a tumor that maybe was found when the patient came into the vet just to have their anal sacs emptied. So the tumor might be 1 centimeter in diameter, and the patient seems pretty well, maybe just getting a bit old, the owners might say. And they've noticed that the dog's not so energetic at exercise, but they put that down to their age. And then you could take an X-ray and get something like this. And so we have lots of small nodules, very clear one there, but they're all over, as you can see. These are interstitial nodules. They're not in the airways, and so they don't really have an impact on airway function. So this can be completely hidden from the owner unless you do the X-ray. Treatment I'll talk about in a minute. Stage 3B means big lymph nodes over 4.5 centimeters in diameter. In this image here, you've got a really big one, nearly 9 centimeters in diameter. We actually took this patient to surgery and they didn't do very well. Just let that be a warning to you. Another stage 3B patient, you can see lymph node here. This is big lymph node, very big. But what I really notice here is all of this feces building up. So the colon's been deflected ventrally, but where you get to the pelvic canal, this lymph node is big going into the pelvic canal. There's a very, very narrow aperture here for passage of feces. That can be the presenting complaint for some of these patients, is that they've got a tumor at the anal sac, but the tumor at the anal sac isn't causing any kind of obstruction to defecation, but the big lymph node definitely can. So trying to get this huge amount of stool through a very narrow gap could be 5 or 6 millimeters, the narrow gap that the stool can't pass through. In an English Cocker Spaniel, the good news is my finger's just the right size. I'm a 7.5 size glove, and I can reach the cranial pelvic brim, and so I can feel those lymph nodes very well. Not so good with a Labrador or a Retriever. My finger's a bit short. I'm pretty sure that 1 or 2 of you will have smiled a little bit at that. I can't see you laughing, which is a little bit sad. But you can put a thumbs up in the chat if you found that loosely amusing. Stage 3A, smaller than 4.5 centimeters. One thing that's really changed over the last 20 years is our ability to recognize these. So we used ultrasound pretty much exclusively to diagnose and stage these patients 20 years ago. Now we use CT pretty much exclusively. And there's a difference for sure in our accuracy. We are able to recognize lymph nodes that would have been missed, not just for technical reasons and for capability reasons, but we also miss lymph nodes that are inside the pelvis that we wouldn't be able to see by ultrasound, which you can detect very easily on CT. This was William, who we've already come across right at the start. So William had a large primary tumor, but no evidence of metastasis. And because I'm not doing the slideshow, you can't see. Yeah, let's get rid of that. So this is an interesting one. Molly was a Cocker Spaniel, which on CT had mildly enlarged, bilateral, mildly enlarged lymph nodes in the medial iliac and external iliac locations. This lymph node here was big enough for me to say, I think that's metastatic. These two, if they were the only thing we'd had, I wouldn't have said that they were metastatic. This CT was taken 1 year later. So we took those lymph nodes out. All of them, all 3 of them, were shown to be non-metastatic, hyperplastic. And we scanned again a year later, more or less, and she remained in remission. And that's become a standard of care for us with our stage 1 tumours. CT and surgery, and then re-CT after a year. When we were using ultrasound to image these cases, we would repeat the ultrasound every 4 months for the first year, and then every 6 months for the next 2 years. But CT gives us better resolution, and we're happy now. We've stopped doing scans at 2 years now. We just do them after 1 year. If they're all clear, we say they're cured.
Okay, Gerry, I have a rather naive question. So I'm sure all the veterinaries are now laughing at me, but you mentioned ultrasound, was it X-rays and CT scan. So would you recommend CT scan to start with for every patient, or start with ultrasound to see if there's something wrong, and if unsure, then continue with CT scan?
It's a really good point, and sorry for not being clearer. I'm talking about what we do.
Yeah.
We have a CT scanner and we're very comfortable using it. Not everybody has access to CT, and it was never wrong that we used X-ray and ultrasound to define the extent of disease, to define the clinical stage. So you've got to use the tools that you've got. If you've got the freedom to choose, then I would always choose CT over X-ray and ultrasound. And we use ultrasound to examine the abdomen and X-ray to examine the thorax, the lungs.
Right. Yeah.
CT can do both, so it's just one test. But for most hospitals, CT would be more expensive than the combination of X-ray and ultrasound. And so we make decisions based upon what's available, what the cost is, what our level of concern is. The quality of the information from CT does mean we can do it less often, so that actually means the cost ends up being lower than it would do if we did more frequent assessments by ultrasound and or X-ray.
Right.
Another interesting point, actually, we used to perform X-ray and ultrasound every time a patient was checked.
Okay.
And then there came a point where we realized we didn't need to keep doing the X-rays. The X-rays wouldn't really change anything. If we found evidence of cancer spread in the lungs but not in the abdomen, we didn't have a treatment that we could offer. So we started just doing ultrasound and only then doing an X-ray if the ultrasound showed us something where we needed to make a decision. So if the ultrasound was all clear, we wouldn't X-ray. And that was good because the ultrasound could be done conscious. X-ray generally required sedation. If the ultrasound showed us a modest lymph node enlargement and we had a conversation about whether it was worth doing an operation just to remove that lymph node, then of course we would do the X-ray before going ahead to make sure there wasn't spread further afield.
Yeah.
So that's a perfectly good way of doing it if CT isn't accessible, and we're keen to minimize sedation and save customers money.
Okay, thanks again.
Thank you. So the beauty of the clinical stage is that it has allowed us to explore treatment strategies in small patient groups. By small isn't the word actually. It's allowed us to explore treatment strategies in defined patient groups. If we took all dogs with anal sac tumor and said, does radiation work? That group is so diverse that it would work for some patients, but it wouldn't work for others. And we would end up not learning how to make the best use of radiation therapy. If we define a very clear patient subgroup that has a less diverse outcome, and we apply radiation therapy, then we might start to see if there's a real impact of that treatment. And we did this with the stage 3B tumors. So these are patients with big metastatic lymph nodes, more than 4.5 centimeters, but without metastasis to other sites like the lungs, the liver, or the spleen. And we combined data from my patients who'd undergone surgery for these for the disease with patients from the hospital in Vienna who'd undergone radiation therapy for what were comparable burdens of disease. And what you can see very clearly from these two graphs, so the graph on the left is interval from treatment till evidence of disease recurrence. On the right is interval from treatment to death, but they're pretty much the same. What we saw was radiation is a lot better than surgery. And we needed this information. I'm sad to say that a number of the oncology community are still coming to terms with this and still feel that surgery has a meaningful place in the management of these cases. I suppose it does if you don't have access to the radiation, but in my community of veterinary oncologists, I think the evidence is really clear, and there's a very stark difference in outcomes between these two. I love this. I think this is amazing. So although it's my patients who didn't do very well, this is how we make progress. We actually, if we have a defined, well-defined patient group that has minimal variability, in their outcomes, then we can genuinely test whether something makes a difference to outcome. If you've got a lot of variability in outcome, you can't so easily recognize additional variation layered on top of that because of the intervention that you perform, whether it was a treatment or something else.
Yeah, that's really interesting. I think currently radiation therapy is not available in Finland.
Yes, well,
all.
I'm sure that fine,
Yeah.
but that makes it tricky.
Yes, it does.
But the scientific principle is beautiful.
Yeah. So would then probably send patients to Sweden or to the UK or Switzerland or somewhere where there was.
Yeah, or we say this just isn't something we can do. And then if we could do surgery, and surgery may give us a life expectancy of about 6 months, or we could do nothing at all, and nothing at all might give us a life expectancy of 2 weeks to 4 months.
Yeah.
But it's just, I think, important that we now have demonstrated what the outcome with surgery is, and that there is something different. But
absolutely.
Thank you. You've helped me make the point that I love that this clinical stage schema has allowed us to then do better stuff, better science. And so there's other examples of this too, that we've done a study recently where we only evaluated the stage 2 anal sac tumours because they're actually quite unusual. There's nothing really written about those except in papers talking about broader groups, but they're not really picked out as a single entity, which means that people don't know how to treat them. So the top reference here is the stage 2 one. The bottom one I've made reference to earlier in the presentation, and this was the recent attempt to try and improve upon the clinical stage scheme that we have, and we didn't really improve on it, which is great. It means that we're all doing the right thing. So we've done, we haven't finished with today yet. We're nearly finished with today. We're going to move on to tomorrow in a second. So treatment is defined by clinical stage of disease. So with stage 1 cases, and I guess for all the practically minded people in the audience who've been waiting and waiting for something useful, and this is the useful bit. This is where we tell you what you can do with these cases today. So stage 1 cases, they are cured by surgery a lot of the time. If you've got access to CT, redoing it after 12 months is a really great way of demonstrating that they're still in remission. We don't do anything more after that now. We say you're probably cured. Come back if you want to, but we can't put our hand on our heart and tell you that it's worth spending money on further monitoring because we think we've probably fixed it. Stage 2, surgery definitely makes a difference. We now use radiation, if the client can afford it, of the primary tumour site, and we irradiate the lymph nodes, even though the lymph nodes were normal on imaging prior to surgery. And we believe that about 2/3 of these cases will go on to develop lymph node metastasis if we don't irradiate the lymph nodes. So this is our way of trying to capture that problem while it's most responsive to treatment. And we would monitor these cases in case further intervention is warranted. Patients with lymph node metastasis but small lymph nodes, we do remove the small lymph nodes and we follow it with radiation therapy, just like we did with the stage 2 ones, and we monitor them. The patients with big lymph nodes, we don't operate on those anymore, and we just manage them with radiation therapy. And then extraordinarily, Palladia, a tyrosine kinase inhibitor that targets many, many things, but one of the things that it targets, well, it targets the KIT growth factor receptor, which is famous for developing high-grade mast cell tumours, but it also targets other molecules which are very similar. And one of those is platelet-derived growth factor receptor, which happens to be expressed in a number of anal sac tumours, which we'll talk about in a moment. The point that I'm making here is that it's imaging that tells us the clinical stage, and it's the clinical stage that defines our medical decision making and that defines outcome. That's good. This is a really strong position for us to be in, and we can carry on like this for another 50 years and that will be fine. But if there's going to be a change, it will be a change where we move from defining outcome by burden of disease, clinical stage, to defining outcome by an understanding of the biological characteristics of a tumour. And we can do that in more ways than just doing a CT or X-rays or ultrasound. And this is why it's so relevant to be talking in this forum. Cell-free DNA has many potential applications in oncology. I've listed what I think those applications could be on this slide. But when I press this, what you'll notice is that some of these, well, they've all changed colour. So this is my opinion, and you're all welcome to have different opinions. If we're talking about anal sac tumours, I don't think that doing a blood test to screen for that tumour is sensible. The prevalence of anal sac tumours is small. It's something like, I can't remember now, but it's something like 0.017% of patients would develop an anal sac tumour. I want to say it's even less than that. It's not high, and the screening is valuable when you've got a high prevalence finding that is pre-cancerous, that could lead to an intervention that means that cancer doesn't develop. So we don't have a precancerous state. There's a low prevalence of disease. There isn't a case for developing screening for this cancer. We could look at cell-free DNA for early detection of cancer, but in the context of anal sac tumours, I don't believe that there's that technology yet. Doesn't mean it couldn't be developed, but seriously, there's a very, very effective early detection tool which could be free. It would be much cheaper for your client for you to stick your finger up their dog's bottom than it would be for you to take a blood sample and send it away. Probably much quicker result as well. And honestly, the number of patients that I have seen in my life where the referral, the history, the medical history says lump found in anal sac, will try antibiotics, and they never go away because they're never antibiotic responsive. If you get a small nodule in an anal sac that feels like a hard pea, it's not an infection. Infections are red and big and sore and painful and swollen. Something little and hard and round is a tumour. So you have the means to detect and diagnose these tumours instantly without the need for cell-free DNA. What about the next one? So definitely cell-free DNA would be helpful in recognition of metastasis. Currently, we're talking about doing X-ray and ultrasound. We're talking about doing CT to look for evidence of metastasis, and those tests are very useful and very standard. I wouldn't use a blood test which told me there probably was metastasis to make my decisions. I would use what I'm familiar with, which would be imaging, to make my decisions. But I can see a role for a cell-free DNA test to identify metastasis which perhaps isn't detected by CT. So that could be that's in other sites. We don't image the brain when we CT patients because the resolution would be so poor that we don't think we would find anything. If a patient had a metastasis that was findable, they'd have neurological signs. But maybe there are metastases which are findable by blood test. We don't really see brain metastasis with anal sac tumours, so maybe I've just got excited about this one because I can imagine other cancers that have a real application here. I'm thinking of hemangiosarcoma in particular. Trouble with that is that you kind of assume hemangiosarcoma has metastasis anyway, so maybe that wouldn't be so useful. And what about the detection of minimal residual disease? That's certainly something that people have been toying with lymphoma. What we learned from lymphoma is that if you do a blood test to tell you that the patient has its lymphoma coming back, and the test tells you, let's say 4 weeks before the lymphoma is detectable, we don't know yet whether doing chemotherapy again sooner would make a difference to that patient. Probably it would. And what we really need to do is to get a bunch of those patients with just detected minimal residual disease, a really closely defined group like we had with the stratification by clinical stage, and then give half of them chemo early and give half of them the chemo at a normal time and see what happens, and then we could find out. So maybe this tool doesn't just allow us to recognize minimal residual disease in this context. Maybe it actually enables us to take a step forward and understand disease progression better and understand our clinical options better. With anal sac tumors, you know, it could replace the serial imaging tests that we do. If we've got access to a CT scan, you still would have to get good quality CT images. We're talking about a full general anesthetic. We do a lot of our rechecks under sedation, but we're aware that the image quality isn't quite the same under sedation. So actually, there could be a case for using a blood test as a way of defining minimal residual disease, or maybe leading you to undertake imaging investigations. We could do fewer imaging investigations, only doing them when the minimal residual disease test yielded a positive, as an example. And then the proof of effective treatment. If there was a molecular marker that said that your treatment was now, your cancer was well controlled, this is a kind of looking at minimal residual disease from the other angle, I suppose. We could look at performing this test following a defined period of treatment, whether that's surgery, chemotherapy, radiation therapy. Again, with anal sac tumor, it's difficult to see how that would have a good application. Perhaps we could find a difference in the cell-free DNA markers of patients who've undergone radiation therapy and have a better outcome or a poorer outcome. I don't think we would use it to verify complete removal of disease surgically, because we feel we've already done that by performing the operation. So the last one, the one I put in green, was to define treatment. And this is where I think the real change will come. There are human cancer examples where lung tumors, for instance, are stratified according to whether they express a growth factor receptor or not. So this would be a bit like doing the c-Kit testing to determine whether a patient's mast cell tumor is going to respond to Masivet or Palladia. There are other tyrosine kinase inhibitors and other small molecule therapeutics, which you would only give to patients who'd got prior molecular testing to show you that that tumor is going to respond. And I bet you that all of our clinical stage and histological categorization of disease will be overtaken by molecular definition of whatever it is that underlies the cancer process in that patient, so that we can start to pick treatments off the shelf according to molecular changes rather than physical burden of disease or histological type, anal sac tumor in this case.
Great. May I interfere?
Absolutely.
Great. So in the previous slide, you had, this one. A lot of different cases. I must say that I partially agree, partially disagree, and partially don't know. So currently we have really good results especially for the treatment monitoring from various diseases. Of course, the groups are fairly small, so we have more dogs in lymphoma and mast cell tumors, and then a handful of cases each for other disease types. We don't have any anal sac tumors, I think, so far. So it will be interesting to see how that goes. But even for mast cell tumors, it is quite clear that the level of cell-free DNA follows closely treatment success. And then you can see very quickly if something goes wrong, if the disease is coming back. With lymphoma, those changes are much bigger, but even with mast cell tumors, you can see these small fluctuations. What is really important there is you need to control for all the pre-analytical factors possible, because cell-free DNA is so unstable molecule, so it's easy to lose most of the cell-free DNA on the way before you can actually analyze it. And for the screening and early detection, I don't think you can see, especially adenocarcinomas, just looking at the level of cell-free DNA, because the fluctuations are so small. So you can see systemic cancers better, but we are developing very sensitive assays that will react to the changes in the source of origin of cell-free DNA, so which tissues they come from. So then it would be possible to see very, very small amounts in the bloodstream. Whether, again, that works for adenocarcinomas remains to be seen. We're currently working in an international collaboration on gastric cancer, which is also very hard to see. So if that works, then fingers crossed. But we will need then good quality samples, well-characterized samples of anal sac carcinomas as well, to be able to do this. So yeah, definitely works for treatment monitoring. Minimal residual disease, again, depends on the cancer type. But yeah.
Thank you very much, Katja.
Yeah, it's just various comments.
Yeah, absolutely. Thank you. And so these are patients that, so the two on the right are both William, but these are patients who all presented with similar, with tumours that we believed could be responsive to chemotherapy. So here's an illustration I wanted to suggest where it would be useful to have some kind of way of discriminating from the patient whose cancer is going to respond to treatment from a patient whose cancer is not going to respond to treatment. At the top left, we have a dog called Kudu, and Kudu had an anal sac tumour. We removed the tumour. The owner, this was a stage 2. The owner didn't want radiation therapy. We talked about chemotherapy, and they declined, instead preferring to just monitor. And we did that, and we monitored him for 7 years, and it never ever came back. Now, we could have given that dog chemotherapy, and that would have been a wrong decision. Wouldn't it be lovely to know beforehand that that was going to be the case? And William did receive chemotherapy, but his chemotherapy didn't work. Again, wouldn't it be nice to know that beforehand? There's risk and cost associated with it. And then just to confuse everything, Archie is the pointer on the bottom left. Archie had a reasonably small primary anal sac tumour, but quite big metastatic lymph nodes. It was a stage 3A, so they were less than 4.5 centimetres, but they were pretty big. We took those out, and we gave him chemotherapy, 1 course of 4 treatments. We assured his owners that the cancer would be back within a year, and we would need to do more surgery, and it never came back. And so I believe that his was a very chemo-responsive tumour. So this was my little montage to say, wouldn't it be nice if we had a way of discriminating these responsiveness or need for chemo or other treatment using some kind of biomarker, maybe cell-free DNA, something that reflects the biology of the tumour. And I've made a reference to tyrosine kinase inhibitors. So here is an example of a treatment that we could choose to use, but when a bunch of anal sac tumours were studied to see the prevalence of PDGFR, platelet-derived growth factor receptor positivity, only 19.5% of them were positive. This is relevant because Palladia and Massivet interact with PDGFR receptor. So they could be treatments for this cancer if PDGFR is overexpressed and important to cancer development. But only 1 in 5 cases actually seems to express it. Again, wouldn't it be good? We could stratify patients according to a treatment that they are going to respond to, if only, you know, we have to get that information first, but this could be a direction of travel. And I finish with a picture of the Whitaker family. I've treated 2 of their Cocker Spaniels for anal sac tumours. Freddie is the one in the middle, and he was the most recent. He had a stage 1 tumour. Freddie, I believe, was cured of his cancer. And I feel like this picture is the perfect ending to a talk about anal sac tumours. So there we go.
Thank you, Gerry. That is truly inspiring, and I have so many questions, but I know also we are running out of time. So I'm going to check if there are any other questions in the Q&A. Not at the moment. So I think that was all from us today. And I would like to thank all the participants. Of course, I would like especially thank you to you, Gerry, for taking the time to be with us today. Thank you so much. And I would like to thank my colleague Anssi, who organized this webinar and sent invitations. He will send the link to the recording after this webinar. Please contact him directly if you have any questions about the webinar or about our company, or if you would like to start collaborating with us. And just a reminder to everyone that this is a monthly seminar series, and our next guest will be Arno Roos from the Netherlands. He will talk on 8th of April about new treatment options for transitional cell carcinomas and hemangiosarcomas. Hope to see you in a month. Thank you, and have a lovely rest of the evening.
Thank you.
Thanks a lot.